All right, hi guys, and welcome back to our podcast, Body by Dawn with David and Dawn. And today we have our guest here, Dr. Carson, who is a functional medicine doctor here locally in Raleigh. And we're going to just pound him with questions today. Some of you guys have written in and given us questions to lob at him, and we have some of our own. But I will let him tell first a little bit about who he is and what he does, and a little bit about their practice.
All right. Well, hey, first of all, thank you for having me here, Dawn and David. So let's see where to start. I'll initially, before going into the type of practice, what type of medicine I'll practice, I'd like to just give an understanding of background about my paradigm and how that was shaped. Mm-hmm. And so when I finished undergrad, I was always interested in the health and sciences field. Never particularly good at one sport, but I played multiple sports, did some dancing, and that led me to go to personal training.
Okay, hold on, we gotta back up for a second. Did you say dancing?
I did tap and jazz for a while.
Wow, did not know that.
And so, definitely had appreciation for kinesthetics and movement and the impact on health. And again, medicine was nowhere on my radar. In fact, I wanted to be an actor. I wanted to be in the big screen. Okay. So I went to LA to be a personal trainer and to kind of pay the bills. Okay. While I tried to get my foot in the door in acting. I did that for a couple of years, and as I grew on, I grew more curious about the body, the health and disease process, and realized it might be 65 by the time I make it as an actor.
You have to look for it.
That's right.
Now I'll still save that for retirement. But as I did that, there was a pivotal kind of key moment in my life where a grandfather of mine was going through the conventional medicine process, type 2 diabetic, and head to toe, half the foot, below the knee, and above the knee, and flew home to Lynchburg, Virginia to see him one of his last times, and he's in a nursing home. And I could tell at that point grossly dehydrated. He was writhing in phantom leg pain syndrome, but the nurse was still coming. He's taking 12 pills 3 times a day, right? And so I wanted to further my curiosity and understanding and knowledge base about the body, but all I knew was the medical complex, which I associated with allopathic medicine or MD. It just didn't feel right. Then I discovered osteopathic medicine. And a doctor of osteopathy and kind of read the tenets and it rang true with me. I said, hey, that's the route to go. So went back, went to Virginia College of Osteopathic Medicine. And once you go to residency right now, the trainings are so merged that you end up drinking inevitably the conventional Kool-Aid, which is great. I think that makes me a little bit better at what I do from a functional standpoint. So completing the internal medicine residency, wore a pager, worked in the hospital for a couple of years. And my goal was always to get back to that job satisfaction as a personal trainer, right?
Of helping people.
And right when I finished residency, rather than start my own practice, I had my home mortgage without the home student debt. So I went with a pager and worked in the hospital, and then eventually got kind of burned out from that. So I started working in an outpatient underserved clinic in rural Oklahoma. And it was there I had a healthy 60-year-old female come to me and say, hey, will you refill my topical estrogen, progesterone, and testosterone? And I thought, I wasn't taught anything about this, right? And I started asking my OB-GYN colleagues, started reading and opened up Pandora's box. And that was it. From there, I discovered the American Academy of Anti-Aging Regenerative Medicine, A4M. That's really what I was searching for when I was looking for the truth in health and disease. Best investment dollars I ever spent. I go to another conference. I say, had I not discovered that consortium, I probably wouldn't be practicing medicine today. Outstanding, everything from nutrition to exercise prescription to supplements to peptides to IV therapy, gut health, sleep. And so it really tied it in, and here I am 5 years later after starting my own practice in Raleigh, North Carolina. And it's a triangle functional medicine. People say, what kind of medicine do you practice? And somewhat truthful, but cynical side, I'll say, hey, it's just kind of rational medicine. Once you have an understanding of the body, you just kind of, either take things away or put things back in place. But I focus a lot on the aging process. So I still manage chronic comorbidities. I get a lot of weight loss, fatigue, diabetes, hypertension. And if you look at the fun part, if I get, healthy people that come to me, it's just exercise performance. But there's a strong correlation between overcoming the disease process and performance enhancement. So both pathologically in some of those pathways and some of the same concepts that you use with it. So.
And then you have a few things that are more your specialty, right? I think I saw that on the website that you kind of focus a little more on. What are those things?
So as far as a focus, I'll say my passion going into weight loss and still today was really weight loss, or specifically body composition.
Okay.
But my family history, I've got real strong focus and advocacy for vascular health and diabetes, metabolic health. But I kind of feel what people are coming into for. Different than in conventional medicine, when we go get our annual labs and hey, you're slightly outside the box here, you need this medication.
Yeah.
Always start those lab reviews with, let's put them in context. What are your acute issues going on? Is it poor sleep, loose stools, whatever it is? Yeah. And that way you're not driven down a rabbit hole by the lab that maybe doesn't correlate.
Yeah, exactly. So again, the total picture, because that's what I've talked a lot about with my clients is like when they're going to their MDs or whatever, a lot of times they're doing that. They're just like, they're looking down the center of a pinhole. And I'm like, yeah, but what about all of these things that are, like, did you tell them about all this? They don't care about that. I'm like, they need to, because the whole picture, what if it's not even what the pathway that they're looking at? And it could be that you've got a vitamin deficiency somewhere, but they're not even looking into that. And they're going to treat you for something that, taking a hammer to it when it really doesn't require a huge, sledgehammer. Something that just, let's maybe some vitamin D and you're okay. Something that minute or that small. But so with that being said, you had mentioned diabetes and things like that. So one of the questions that I did have was somebody had asked, do you guys test for insulin levels when they come into your office? So you clearly do that. I
do. There's a number of things that you can do, but specifically look at fasting glucose, one spot at a time, fasting insulin, one spot at a time. To me, the most important lab, 95, 90%, 97% of my clients that I check is the hemoglobin A1C. The most important, right? And I say that exception for the small percent that are either following up on a cancer tumor marker or something like that. But otherwise, that's the most important lab. My healthy people every 3 months. Right, and in conventional medicine, what we're taught is, hey, you've got this range on 6'5" and higher is diabetes, 5'7" to 6'4", you're pre-diabetes, and we'll wait to somewhere in that pre-diabetic range and say, don't go exercise more, eat better, right? And it's kind of left that short. And so the sweet spot, and again, this is part of our endocrine system, so it's a key endocrine hormone relationship with the insulin portion of it. In my understanding, ideal spot is 480 to 5:1. That's perfect, 480 to 5:1. And certainly routine exercise is a great insulin sensitizer. High fiber, nutrient dense diet plays a big role, but I think there's two commonly things that are overlooked. There's probably more to it. One of them is the hypothalamic pituitary adrenal axis, stress axis. Cortisol's high. We're in the 21st world century. You've got a cell phone in your pocket in traffic. We're in sympathetic overtone, right? The majority of us. And so when cortisol's high, it stimulates gluconeogenesis from the liver, higher glucose. And then the fourth component is really your micronutrient status, levels of chromium, vanadium, molybdenum. Vitamin D helps express that insulin receptor, magnesium, all those key nutrients play a role in it. And so rarely is it, I look and say, hey, which one of those four is low-hanging fruit? Which one is it? Sleep, we're not sleeping restoratively every night. Interestingly, so I had a 63-year-old gentleman a couple of years ago. He was top 3 in the nation in Ironman, podium, top 3 in the nation. A1C pre-diabetic. So in fact, he was probably over-exercising.
Exactly.
Like we hear this term over-exercising, and some of this pre-workout stuff had some fructose and stuff. But it's not as simple as, hey, exercise more, eat less.
So in a situation like that, what was the fix for him?
So that's a struggle because I appreciate the therapeutic benefits of exercise, and you like that. You like that running, but we spoke about
overdoing
it. Spoke about overdoing it, right? And give yourself optimal rest, and we talked about his pre-workout stuff that had some of the quick-acting glucose things in it. But that'd be the strategy.
Okay, to overcome that. Okay, cool. And I think somebody had even mentioned on that note, because they were asking about heavy metals, parasites and heavy metals detoxing. Which ones are better? What are they good for? And who should take them? So I guess you're obviously going to see all that when you're doing blood work with these people. Or are you doing this through saliva testing, or saliva is for just hormonal? Is that just for cortisol levels? So
there's a number of ways you can do it. Typically, if I'm doing heavy metals, I'll do a urine collection. But there's plenty of people who are versed in hair sampling. You may be able to, I'm not sure if I'm aware of salivary samples for heavy metals specifically. And so if I have people specifically coming looking for that, I'll look at their history and look at what their symptoms are like and say, hey, does this make sense? Several years ago when I first opened my practice, Duke, for instance, I'm a Carolina fan, still love ACC, but Duke has their executive exam, right? And it was a couple grand, more than a couple grand, right? And I had a couple friends that went through it, and they get a couple LabCorp exams or labs. It probably costs them less than $50 to get this, but they get an 8-hour exam, you get your prostate exam, you get your treadmill stress. There's some good stuff in there, chat with your nutritionist. But from my perspective, my experience, it was, there's a small subset of people that may serve well. Hey, if I need my ACL repaired and I can only have a Stanford trained, Harvard fellowship, then that class of people, that's fine, right? That's definitely not me. But you can spend a ton of money on testing. And so similarly, I tell people, hey, you can spend 10 grand on testing stool, your own DNA, your parasites, heavy metals. And what I try to do, look at, and this comes from my experience, worked in a triple wide trailer for the underserved. What's the return on my investment? Right? What's the return on my investment? And so I try to make testing now much more focused. And there's some people that want to come in, there's the new, Prevenu, it's a full body MRI. Right now, it's a couple grand. And with all the advancement of new testing, whether it's a salivary or with imaging, you got to appreciate that unintended consequences, right? Because we go image 100 people's backs, a couple surgeons say, hey, you need back surgery, right? You're walking around, you're active, fine, or hey, I need a biopsy and put a needle in that. But if we feel like there's been a historical exposure, or if we can't figure out what's going on, we're trying to overturn stones, then usually when I do a heavy metal testing, I'll do it provoked. My understanding is with heavy metals, if we have exposure to heavy metal, arsen's been the number one, or say the mercury, you drink from the thermometer, it'll stay in the bloodstream for about 2 to 3 weeks. So if you check it acutely from that exposure, you'll find the bloodstream, but otherwise, it will go seed in different organ systems. Lead, for instance, hits that long bone, femur and tibia, you get a little bit in pancreas, brain. Mercury hits that central nervous system, but a little bit in other organs. So when I say provoked, I'll use, it's an oral prescription, DMSA, and so it will bind that and bring it out of your tissue, and then we capture urine 6 to 12 hours and measure what comes out. Ideally, you do one unprovoked, you see where your baseline is, and you do it provoked. I've seen enough of them now where I try to make a guesstimate on, hey, this is really off the charts. Here's the potential impact. Try to find what exposure sources are. Is it recent or is it old exposure? But it's it's really an interesting rabbit hole to go down. 6 or 7 years ago when I did my fellowship in anti-aging, there's great lectures and presentations on when bones start to degenerate in the mid-40s, right? Bone density starts to degenerate and starting to leach heavy metals that we expose, increase incidence of incarceration in mental health disorders in that time frame associated with it. Yeah, it really is. Really is. But is this something that 350 million people need to go test for? Yeah, I'm not sure that.
So basically, when people are coming to you, I know because I've been through this process with you. There's a lot of questions, a huge questionnaire that you're filling out. So basically, it kind of tells you what you need to kind of focus on more or less, because you can't come in and just go, we're going to look at everything. Even though we are from a functional medicine perspective, we're looking at the whole picture, but we have to start somewhere. So it's like, well, where do we start? So when they come to you, they're filling out a form online, answering a bunch of questions that you could then kind of target where do we need to start unraveling this ball of yarn, right? And it may lead to, okay, let's get these tests done, and then they just come back, okay, now we might need to see something else, correct? So that's good. The question came in, parasites and heavy metal detoxes. So do you offer things to detox from heavy metals? Is that an offering of yours?
I do. There's, I think from a high level, there's generalized detox, and I'll use one particular company. I've done dozens of them, and it's not specific for parasites, specific for heavy metal, but it helps. And when we talk about detox, it's a key part of aging well, right? Even in our healthy people, you want to keep your, like we said, insulin glucose, all your endocrine, your thyroid, all those in an optimal youthful range. Same thing when you look from a high level, and we're asking our liver, our kidney, and our lymphatic system to live in the 21st world century.
Yeah.
Right? You've seen the Instagram post on the microplastics I'm getting from Starbucks
yes,
cup.
exactly.
I can tolerate it today,
Yes.
but I do this daily for 40 years. The more decades you've been on Earth,
Yes.
the longer you want to start those detoxifications. And so I think a good general rule of thumb is say once a quarter, can have 5 to 7 days, anti-inflammatory Mediterranean type diet, filtered water, and maybe take a few supplements to support that gallbladder and liver. Once a year, we should ideally do it all, do it 2 weeks at a time.
Okay.
But there's specific things you can also do to target specific parasites, whether it's pharmaceutical or supplements.
Okay. What do you think about all the newest stuff that I've been hearing is that cancer is basically just parasites in the body? Is that true, or is that's just stuff that's floating around on the internet?
Yeah.
Right now?
Interesting concept. I always say, Bloom, hey, is there an open link correlation there? Usually, if I'm thinking cancer, it's a dysregulation in the immune system. So, inevitably, you could say, hey, this parasite is stealing nutrients, disrupting the immune system, and maybe there's a link there. But I wouldn't say, hey, that's a common source. The common source of it. I think there's plenty of other environmental contaminants, toxins.
Issues. I keep seeing that on social media. Every time I pop on there, like all I'm getting on my feed is about the fact that the parasites are just really all it is. And that's what cancer is. And there's so much. That's the thing is why we need folks like you is because there's so much information out there that to sift through that you just get confused as the layman person sitting there reading it all. Like, well, is that really what it is? Then I just need to do the parasite cleanse, and then I don't have to worry about cancer anymore. You know what I mean? It's those kind of things that can kind of send people almost, off, like you said, down a rabbit hole that can be very confusing. I had another lady. She's on the backside of breast cancer.
Okay.
But she's now on an estrogen blocker, and she's in her 60s, right? So. Is there something I can do to manage the weight gain for the midsection? Because she's like, I know that, diet plays a big role. She said, but without going on a crazy strict diet, she works out all the time. She's one of our boot campers. She lifts heavy. She's in there doing her cardio and everything else. And she's doing great right now. But is it tamoxifen? That's what she's taking, but again, all the estrogen's been blocked. So she's like, what's causing me to gain weight, and what can I do? Is there a natural? She wanted to know, is there a natural? And I told them, I said, well, he's big on peptides. He does a lot with peptides. There may be a peptide that can help with that. And then let me throw this one at you too, kind of zinging it at you. But the BPC 157, I don't know if that's something that relates to this at all, but we want to get into that as well. So would that be something that would help her in that case, or is it?
So I love BPC. I would put it in the water. It's not my go-to as far as body composition improvement.
Okay.
I think coming back to this case, and I see this all the time, and this one's a struggle, right? When we look at it's the heart doctor wants to look after the heart. Breast oncologist wants to look after the breast, kidney doctor, GI. And it's what conventional medicine does well. It's what I struggle and don't want to do everything comprehensively. And so we're trying to prevent, and it's number 2, right? Cancer is number 2 cause in the U.S. and breast cancer falls in there. And so important, but for me, when I look at, hey, I've got weight gain and I'm postmenopause, right? That's a big deal, right? And sometimes us men have a tough time relating to it, whether it's premenopausal, and I've got the cycle changing in hormones, or postmenopausal, when we take that gonadal acids. Equivalent, say, let's get castrated. At 50, we'll see how we feel. It seems to be a little bit different.
Exactly.
So that part changes. that loss of endocrine access, maybe not as profuse as taking out your thyroid, and we'll see the weight gain come up, but definitely plays a role. Specifically when you talk about loss of testosterone, it helps hang on to lean muscle mass, right, in men and women. But how I'm trained and the mentors that I learned from is, hey, I'm still a fan of bioidentical hormone replacement in my postmenopausal females. I wouldn't do it the month diagnosis of breast cancer, wait at least a year.
I think it's been about that for her.
Okay, and that's when I would reconsider it. And it's tough being in this spot medical legally, but my family members, what I would advocate for when you look at the role of the different hormones, the ovaries primarily make 3 different estrogens: E1, E2, and E3. Estrone, estradiol, and estriol. Estradiol is the one we commonly hear about. It's the most dominant estrogen in a premenopausal female.
Right.
Once we go through menopause, estrone, E1, becomes the most dominant.
Okay.
And each one of those estrogens have different binding affinities to estrogen receptors on the breast. Right?
Okay.
E3, estriol, gets most of its impact on the genitourinary system, but it also helps competitively block estrone. And so, for instance, when estrone binds that estrogen receptor alpha, it increases breast cell proliferation, and that's what can drive that. So the tamoxifen and other medications that block that estradiol, hey, we're looking for kind of that short term and risk of not propagating or having a recurrence of breast cancer, but at the cost of bone density, at the cost of skin integrity, at the cost of cognition.
Yes.
Any post-menopausal female that comes to me with a cognitive issue, forget the keys, forget faces, it's an estradiol deficiency until proven otherwise. And so it's a matter of like looking at risk and benefit. I'm not saying, hey, everybody diagnosed with breast cancer needs to go on HRT right away, but having an honest conversation specifically in the oncology world, conventional oncology, it's tough to find somebody who's open and appreciates that whole picture.
Yeah. And one of the things that I had mentioned to her is, and I don't know how this plays into it, but testosterone. Like in this case, would this be a case where you would prescribe testosterone to this female?
I would certainly consider it on the timing of it, right? You want to look at testing of it, but if this is, hey, I'm 62, I haven't had menses in 5-7 years, pretty straightforward. We're kind of doing that more to kind of check the box on it. The other thing to think about, right, when we go through, I commonly refer to the anterior pituitary in the brain as kind of the flight control center at the airport, right? We got planes coming in and out, or a plane with several engines. So we got 6 major hormones that come out. You got your thyroid, stimulating hormone, thyroid axis. Then LH and FSH send signals to the gonads, your testosterone, release of follicle, or spermatogenesis. You got your growth hormone that comes in, then you got ACTHR, adrenal hormone, and you want all those balanced, right? You can go to some T clinics down the street. I don't care how what age, what gender. We just bump testosterone. Everybody feels better short term. But my goal is to try to balance and optimize those hormones, that endocrine system, to where we're in a youthful state and balance those, not hang our heads. So when a woman goes through menopause, it's not just that loss of FSH, LH in that engine, that ovarian engine in the plane. Ooh, that puts a lot of strain on that adrenal axis. It's a stressor in and of itself. Now, say that there's kind of a loose generalization when we gain adipose tissue, gain weight. If it's pretty diffuse, neck, shoulders, arms, midsection, probably thyroid. We're kind of pointing towards thyroid. If you see the females that have really slender upper body, really big hips, it's a mismatch of estrogen-progesterone ratio. And then if we're just seeing that abdominal region primarily, I think about cortisol and that stress axis. So a friend said, hey, she's exercising routinely, but it's kind of midsection. Okay, I would support that adrenal axis, which we do, make sure sleep's dialed in routinely.
So if somebody like that came to you, then it would be more a prescription of lifestyle, or it would be, there's peptides that you would recommend for her, and I mean, again, lifestyle, she's pretty much got that kind of reeled in. I think even her diet is pretty straightforward. It's not strict, but it's not terrible. Oh, look, and I think, so all the above, right? I talk about, and I commonly think, hey, I eat a clean diet, I eat a good diet. It's very much relative. Right. Where I'm raised, my version of a clean diet from where I'm raised is vastly different than a couple of years in Southern California versus where I am now, right? And so when I meet somebody for the first time, it used to be religion, politics, it's nutrition right there. So coming from Southern Virginia, Martinsville, a standard American diet had hookups at all the fast food. I've been plant-based for about 15 years now. I've got an 8, 9, 10, and a 4-year-old kid. That are plant-based, right? We'll have a couple eggs a month. We'll have salmon about once a quarter, but primarily plant-based. I try not to put it in a box. I used to be vegan, used to be raw vegan for a period before kids when I had time. But that's my advocacy for nutrition. So it still plays a role. And by no means am I perfect. But all those things affect it. And certainly I love either perimenopause. If we're not quite ready to replace fully the ovarian part and we're seeing some weight gain and change that despite lifestyle efforts, love the growth hormone modulating peptides. Sermorellin's been around for a while. Tesamorellin's FDA approved. I use a lot of CJC, ipamorelin. That's what I was going to ask you about. So can we back up and the tesamorelin? So tell us a little bit about that, and would that be something probably that might be?
I think so, right? The same thing based on the timing of a tumor. You want to be cautious about that timing, right? The month after, somewhere after 1 to 2 years, I would reconsider that if we're having negative follow-up, just because growth hormone has that propensity of growth. Most people know it for body composition changes, but just like your thyroid, estrogen, it impacts every organ system. But certainly a consideration.
And testosterone, that helps with the weight gain as well, right?
It does. So any of those growth hormone modulating peptides, they're all acting through the pituitary. So different. Some people use it in my space. I think I've used it in the past. Just exogenous growth hormone. Everybody feels better on growth hormone, right? But you run that risk of being supra physiologic, and long term there's some downstream side effects from it. But if you use peptides, right, the string of amino acids that act upstream of the hypothalamus, where you've got your growth hormone releasing hormone and growth hormone inhibitory hormone. As we age, men or women, it's kind of analogous to men's testosterone. Each decade on Earth, just a little bit of decline in that production and secretion. And so with the peptides, you're just asking the pituitary, hey, give me back the production and secretion I had in my 10, 20 years. And it makes a difference. It's not, again, I'll hang a hat on it. You gotta have the lifestyle, still dialing and routine exercise.
So to dumb this down for us, basically is, what I get is that instead of trying to replace something that we've lost, the peptides are basically telling your body, hey, make more of that. Instead of falsely putting it there. It's letting your body, it's just turning that back on in essence.
Exactly. And somewhat analogous, you can use clomiphene or injectable HCG. They've been used in the fertility world, men and women, to stimulate the gonads. And so I've got men saying, hey, I'm not quite ready for TRT. And ethically, I like the idea. Can we squeeze as much of our own endogenous endocrine system as we can?
Yes, absolutely. And I would imagine that, because somebody had also asked the question about HRT, and she was specific to women, but once it's started, you have to continue it. That's what she was asking. Is it for life? Is it for the rest of your life once you start?
That's a great question. I get that all the time. And it really, I think if it's dosed right and you see the clinical outcome, most people say, hey, this is in my healthcare investment budget annually. But it'd be, I think it's kind of a false concept to say, hey, I'm gonna start on testosterone or topical hormones for female, feel great for a while, and then somehow I'm gonna stop that and magically start taking so hopefully, depending on where they are on that process, you'll see that clinical difference, and that, hopefully that's enough to drive it.
Because in my mind, I look at it and go, well, if your body, especially if you're talking about women that, menopausal, your body's not just going to all of a sudden start making estrogen again. Like if you went on, hormone replacement therapies, then what makes you think that your body is it's not going to go back to having that?
It is, right? And before medicine, I think, I had a little bit of the insight coming from a personal trainer into medicine in saying, look, the common adage as we age, you're supposed to lose muscle mass, lose hair, joints hurt, be crotchety, no libido. And if that's people's version of aging, that's okay, right? That's okay. But just like if I don't give a type 2 diabetic that needs insulin, if I don't give them insulin, that aging process accelerates. If I don't give somebody with a severely underactive thyroid that hormone, that aging process accelerates. So same thing when the ovaries tap out, the aging process is going to accelerate. Some people age gracefully, and that's okay. There's a little variation, I think, in the adrenal glands pick up a little bit of what we call that steroidogenic pathway conversion of cholesterol into your sexual hormones. Pick up a little bit of that. But when you look at the aging process, the other thing I want to address, I get this all the time. Hey, Dr. am I going to get estrogen-driven cancer? So some type of cancer.
That was another question.
That's what all my conventional colleagues say. Hey, if I read the headline, not even conspiracy theories, but part of the reason we're not talking about this in conventional medicine is, right, big pharma can't patent specific hormones, right? And if we don't replace those hormones, we don't optimize that endocrine and metabolic system. If we don't replace those, they've got a lot more prescriptions to write. And so that part is probably why we aren't educated on that. But if you just read the headlines, testosterone causes prostate cancer, estrogen causes breast cancer, and look without a medical degree, without even looking at literature, females' estrogen was most dominant in their teens, 20s, and I know there's a few unfortunate cases where those breast cancers happen, but the incidence, 60s postmenopausal. Incidence by far larger. Same thing with prostate cancer. I'm sure there's cases in 20s, 30s, but the incidence, 70s, right, for men. Hair loss, prostate issues, you name it, right? That comes when testosterone is low, so there's a lot more to just say, hey, this causes that. Understanding the different types of estrogens, the changes in the other axes and metabolism that happen there. Two other things I will say, and then I really try to get on my soapbox for any female I see, and I'm sure there's more to it, is the impact of cruciferous vegetables, and specifically a DIM product that helps steer estrogen down the favorable pathway in the liver. There's 3 favorable pathways in the liver. It's that 2-hydroxy that helps facilitate that, and that can help mitigate DNA damages from estrogen being driven down the wrong pathway. And the other thing is your level of iodine. This is literature is about 10 to 12 years old, and it shows that females with a higher status of iodine, it changes how estrogen binds to estrogen receptors on the breast and promotes apoptosis, controlled immune cell death, versus low iodine status estrogen then facilitates proliferation, increased breast cell turnover, and increased risk for cancers there. And so those are 2 things. I'm not saying, hey, those 2 things are ever going to prevent everybody from getting estrogen cancer, but certainly when you're looking at the impact of environmental and lifestyle choices here, those are 2 things I try to get on my soapbox about for both postmenopausal and my younger females as well. Yeah.
So I guess in short, then you are basically aligning with the fact that taking HRT for women that are menopausal is not, as far as increasing your risk for cancer, isn't a huge concern.
It's not. I think that if it's not, the other thing is think about the vehicle of what you do. I am not a fan of oral estrogen. It goes through the liver and has what we call first pass effect, increases inflammatory markers, risk of clotting. They're great at quelling hot flashes, right? But no, I do some pellet therapies. Most of my females are on topical creams. I think it's a little bit easier to mimic Mother Nature when I look at estradiol, replacing estradiol and then estriol, little progesterone.
So you are a fan of the creams then, and what is the? I know people fear that because if you've got the cream, say on your hands, and then you're touching somebody else in the house or something like that, is that a big concern?
I see that. I've definitely seen it periodically over time. Whether it's my female come in and their male spouse is on topical hormones. Hey, what's going on? Okay. And vice versa. I'll see some cross contamination. But yeah, if you put your topical creams on and go use the sink or toilet, and your spouse comes in and do it, you'll see if that's done repetitively, you'll see some cross contamination. But it's not a huge red flag. We will see it or acknowledge that in labs and making course correction, but that's kind of few and far between.
I feel like from the clients that I have that have had the pellets put in, for whatever reason, and just to note, they weren't seeing Dr. Shear, but the pellets, they just seem like, for the people that I've known that have had them, just don't really seem to work, or they just work for a very short amount of time. It's like they just can't quite dial it in right, and I've actually seen some of my female clients, even after having pellet, get more tired, gain weight, do all the opposite of what it was supposed to have done for them. So is that because it's just not as effective that way, or what is causing that?
It's a great question. Well, I think, 2 things. You're primarily when there's a couple large, very successful clinics here that do a lot of pellets, right? And I see their patients periodically, and predominantly it's testosterone. There's some testosterone that's converted into estradiol, and on females you can put some estradiol in there to help balance it. But I've never seen an estriol, right? That third component for the genitourinary system and competitive blocking of estrogen receptors on the breast. With this, so it's not as close to mimicking Mother Nature, and so the few that I have on it, I'm not going to remove the topical creams there. It's the poor compliance. They don't have this is as close to fit. And alternatively, right, from a very economic budget, if you've got Medicare, you got good insurance cover, but can't afford the bioidentical hormone replacement, hey, the topical estradiol patch combined with oral progesterone at night. You always want anybody on hormone replacement, female standpoint, you always want to take some oral progesterone. To help balance that out.
I was gonna get onto that one as well, because the progesterone, in my understanding, is it is responsible for a lot of our sleepless nights as females, right?
It is brilliant. It hits the GABA receptor in the brain, the same as Vino, the same as the benzodiazepines, without the dependent tolerance fashion. I mean, it's phenomenal. And again, nothing, whether it's a peptide or a hormone or supplement, there's always this area under the curve, right? 80% of people respond here to this. We got some that have an over response, we got some that can't tolerate it or have the opposite response. A few outliers here, but oral progesterone, phenomenal sleep aid.
So you may be able to get someone like myself off of a sleep medication with progesterone.
And there, I've had a couple humbling cases, but in most cases, that's certainly postmenopausal female. Hey, start there. There's a couple of great sleep herbs combinations that I'll use, and then same thing factoring. Hey, is this more HPA axis, stress axis driven? But yeah, the oral progesterone, certain doses, extended release or immediate relief, depending on whether sleep onset and sleep maintenance looks like. You can make some pretty individualized changes.
And would that be based off of blood work, or do they have to have like sleep studies and stuff?
I'll always check the progesterone level the first time I check something, but it's from blood work standpoint, it's not one that I routinely check. Usually then, if we're doing hormone replacement therapy, I'll do that salivary sample more because that's a better lab assessment for topical creams. And they can build, ZRT kit that I use will kind of give you an estrogen to progesterone ratio, make sure we're in the sweet spot there. But yeah, great as far as calming, right? And coming back to your female counterpart and dealing with changes in emotion when they go through that change, realizing, we've lost that GABA stimulation, right? And very common to be a little bit more anxious, a little bit more on edge. Certainly, if we take away sleep, consistent restorative sleep, we're going to all be on edge a little bit more, so it plays a big role.
So women go through menopause. We get kind of crazy. We have bone loss. We have weight gain. We have all that. Is there such thing as menopause?
Menopause, yeah. Whatever the term is, I'll say from a medical standpoint or physiologic standpoint, hey, the loss of that hypothalamic pituitary gonadal, HPG axis, right? That's, whether it's part of Newton's law of entropy or degradation over time, just like the insulin A1C. So we'll oftentimes lose the sensitivity and feedback mechanisms. So it's common, more often than not. We'll see men just decade after decade. I mean, I see men in late 20s, early 30s, and it's plummeting. Does that mean we go straight to testosterone replacement therapy? No. And I see some outliers. I've seen some 70-year-olds with, I'm envious of their endogenous testosterone level, right?
One of my clients, which is one of your patients, has really high testosterone levels. And he's not a young buck anymore either. I mean, we're talking about 50s and still has very high testosterone.
That's great. In early on in my education, I started realizing, hey, why is this, right? And it's probably a number of different things, but somewhere in the 70s when we came up with phthalates or plasticizers that turned the hard plastic in the 70s into the soft plastics that we have here, right? We get a little bit of that in utero during gestation, right? Just from mom. It doesn't mean we come out of the womb with not making any testosterone, but those things can decrease it certainly. When you're in fight or flight, again, coming back to that, you're in fight or flight, the way the body works is, I'm not worried about procreating, right? I'm running from the white tiger. Right.
So for men, there's really not necessarily for women, we can basically say you're going to be in perimenopause about age 35, 40, and that's going to last for about 10 years. And so you're going to hit, menopause around 50, 55, maybe something like that. So is there a window for men that we feel like that's where, and I know you said you have some outliers, so some that are in their 70s that maybe have high testosterone, but is there like sort of a generalization to say, okay, men should probably start looking out for these symptoms about this age?
Oh, great question. So, hey, I love it when I see somebody in their early 20s, just to get a baseline, right? Just to get a baseline, and maybe they're coming in for something else, but you see what that is because it's all relative. Like it's when most people are just learning about this, hey, I'm already in my mid-40s or maybe even 50s and I check my testosterone and it's low. Well, can you look back and say, hey, this is when I felt great and we've got a biomarker that says, hey, I was great then and maybe I just lost a loved one, went through a divorce and had this, and maybe this is momentarily low and we can work this back up versus if I see that year after year kind of dwindling, that we may approach that a little bit differently. But clinically, and this is another key one that I share, and we all stereotypically opt to men in testosterone, erection, and libido. Those are important. I manage those things. But clinically, we take a low testosterone, somebody has a low testosterone, to a higher physiologic one. One is improved restorative sleep. Two is improved response to stress and anxiety. Things just roll off your shoulders. Three is mental stamina. Four is exercise capacity. Five, lean muscle mass. Further down, erection libido. So men have about 10 times as much testosterone as females, and so it's not quite as pronounced in females. Every now and then I'll get, hey, energy levels a little bit better, maybe sleep's a little better, but it's not quite as pronounced on that. But definitely, I was a little disappointed when I look at the amount of investment, not just the cost-wise from medical school, but the duration I put in there, and obviously that made me better to where I am now. But the time and effort I put towards A4M and the education that I got through there, and the literature that they put in front of you is much more telling.
Yeah. And I'm just glad that there's folks like you who are actually looking out for that side of things, because at least I feel like from the standpoint of hormones, male or female, that just plays such a huge role in everything. It's not, we're going in talking about, seeing an orthopedic because we've got hip pain or my shoulder's hurting, and they're not looking at the fact that we've got no estrogen. And so that's, frozen shoulders are a big thing for people, and women in menopause, right?
Yeah.
So they're not even looking at that. They're going, well, I mean, we can go in there and let's, if we do some surgery, crack that thing up, and we need doctors like you that will say, okay, let's step back and take a broader, picture before we go hitting at that. Maybe that's not what it is, isn't really what it is. There's something else causing it, I have so many more questions, but David, do you have questions for him?
That's great information. I just want to tell you that. I had a question about depression. Someone asked me about depression, and I'm thinking about working with their spouse. Spouse may be a little bit overweight, so felt that depression is causing the spouse not to want to engage. And it's just like, what do you think that is? Is it medical or really don't know? But it's almost like a cyclical effect of I'm not working out because I'm depressed, so I'm not working out. So any advice?
That is a good one, right? And it's common. I'll say for me personally, it goes hand in hand, right? And I look at just the therapeutic benefits of exercise. Use the analogy, if I go 3-4 days without exercise, my wife's telling me to sleep in a sofa, right? And my food choices are worse. So a number of different things. I think that, coming back to med school, they teach us when the ovaries tap out, when we go through menopause, we offer a selective serotonin reuptake inhibitor to increase serotonin. The ovaries don't make serotonin, right? That 90% of that's made in the gastrointestinal system, right? So I hone in on that and look at the timing of this, what's family history look like. Certainly some genetic predisposition or markers to that. As far as those neurotransmitters and serotonin, even dopamine, helping with that reward cascade. I kind of take that in consideration, but there's a piece that you'd like to mind over matter. Man, go for a walk. Start to get that heart rate. You feel better, right? You get the endorphins, you get some stimulation there. So I think that, that's a piece of it. Getting sleep down in, and then one of the first functional supplements I started years ago was just tryptophan. Right? It's that precursor for serotonin. It first metabolized into melatonin, which is then converted to serotonin. So it can be a good adjuvant to sleep, and then potentially to build those serotonin stores. I don't know if that answers your question as far as cyclical. There's I think
what
a piece
time
of
of
mind
day
in
do you
there.
take your tryptophan? Is that something that people take in the morning? Is it something they take at night? Does it matter what time of day they take it?
It does. So that's probably maybe it's in one of my supplements now, but it was one of the initial ones that I would use. But if you're taking a higher dose, you're going to get the sleep impact. So take that one in the evening. But there's a little correlation clinically. Hey, if I got that sweet tooth, or if I've got the carb craving, sometimes that's appreciated as a serotonin deficiency. You can take a 25 to 50 milligrams once or twice during the day to build those stores without getting the sedation effects.
Okay, that's interesting. So I want to touch on that just a little bit more, because that's a big problem for a lot of people is they want to snack at night. And I tell them, just go to bed. That way you're not sitting in the kitchen and eat anything, right? Don't sit there and play in your pantry. So, but you're saying there may actually be a reason why you're kind of wanting to snack at night.
Yeah, sure. I mean, great. It's right. It's trying to balance with, hey, I still need to apply some mental currency if I go into the gym. I shut the blue light off, screen off, before going to bed, and being able to walk away from the kitchen. But again, it's tougher and tougher in this world. But that PM snacking part. Hey, I like it when particularly if it's kind of carb or sweet tooth related. Hey, we mentioned the tryptophan. Maybe that's opportunity for improvement there. I say, hey, what are we doing gut wise? We have daily bowel movements. Gut, okay, that's the origin and production of serotonin. And alternatively, I could do without the sweets, but it's that salt craving. That may lean towards more dopamine.
Okay.
Right? And that hits that reward cascade, right? And so, if we feel like it's that, and I use this as well with addiction, right? Whether it's food addiction, whether it's any other illicit, cigarettes or alcohol, where we're all driven by that reward cascade and dopamine, right? Whether it's the screen, right, the screen, all driven there. And so tyrosine, phenylalanine, precursor amino acids, kind of get that building block there. But right, if we can consciously think about that, we get that frontal cortex dialed in, and it's like, I want to have that late night salty snack, or hey, drop down, do some push-ups. Can I go for a brisk walk to sprinkle a little dopamine up there?
And that's also been a tactic that I've asked my clients to use. Is like, well, then if you're wanting a snack, go do something else. Get busy. And I've said, go for a walk. If it's like after dinner and it's the time where you normally sit down and watch TV and you start wanting a snack, go outside and go for a walk. And then especially if it's summertime and things like that, and you still, it's warm enough to do it. So that is probably a good strategy.
I like that other subtle behavior change, right? When I'm real good, hey, I'm as soon as dinner's done, I'm brushing my teeth. I'm brushing my teeth, right? Because if there's the struggle for me where my kids are, I'm still tucking kids in, and occasionally may still drift off or fall asleep. And then when I come back down to light, then brushing my teeth, hey, I'm back up. Back up. And it's a little bit easier to sneak in the kitchen. A little bit easier.
You're right.
That's exactly right. And so that's a good point. But that's interesting because I hadn't even thought about it. The tryptophan thing had not even crossed my sight in thinking about, because so many clients deal with that after dinner or right before bedtime cravings. And I think one of my clients, he actually does go to you as well. I've sent him to you as well, but he deals with a lot, and he's lifestyle-wise, he's on point because he works out all the time. He works out hard. He's one of my hardest working clients, and he tries to watch what he eats. I mean, we've got him on the right meal plans, but he'll break that from time to time. But his biggest thing is that right there is just, he's like, I don't know what's wrong with me. I can't. I just get so driven to do that at bedtime. I don't understand why. I'm like, just go to bed. But it may be, something that we could address in a different way.
I think so. And even with that, there are two things we talked about, the BPC momentarily, but certainly we talk about appetite craving. Hopefully you appreciate I've got pretty healthy skepticism in pharma, but with the GLP-1 agonist and their step-ups, I'm a huge fan. As far as risk and benefit, not for everybody.
So you are a fan of GLP-1?
I am. I have this conversation all the time. People read on social media, hey, it's going to cause this. Or it's commonly, I feel like I'm cheating. And it's quickly the calm on, we're not living in a level playing field. Not living in a playing field. When you look at the amount of chemicals that are put in our environment, 21st world century, look at the risk and benefit of the therapies out there, right? And when I look at it, it's not just for weight loss and diabetes. Those things are key, right? That's why they drive down that A1C. But the other pleiotropic or multiple downstream side effects from it, you're seeing remodeling in heart failure patients or patients with heart attack and obesity. It plummets total cholesterol and LDL cholesterol. It plummets. I'm not even seeing that in literature, but at a small to moderate dose, it'll plummet it. And we're seeing literature coming out on decreasing neuroinflammation. In 5 years, I think we're going to see a reduction in Alzheimer's or dementia, Parkinson's, MS from that as well.
Interesting.
It is.
Is it just like with anything else? You're looking at risk and benefit.
Well, that's my question on that, is because the GLP-1s, my understanding is that in a lot of cases, it's a lot of muscle loss that's happening, right? And so if we lose muscle, then that is, that's also the most metabolic organ in our body, right? So how is that playing into it? Because we really need them to, the best thing they can do is to build more muscle to keep their metabolism up. That's going to help them control the weight. And so that's where I get into like conundrum. So I think when we see that, hey, loss in muscle and that propensity to do it is usually in that 15-minute visit. I don't know if the way we want, or the A1C, but we go up to the next dose or Wegovy and Ozempic. Right? We go up and I'll see back in 3 months or 6 months. If you're just hanging your hat on that one and not talking about the importance of sleep, managing stress, or reaching exercise, or when we're eating and what we're eating, and do we have testosterone and growth hormone that really help make a difference in that. If I put every postmenopausal female on just semaglutide and use Ozempic or Wegovy, we're going to lose a lot of skeletal muscle mass. So when I look at body composition in there, men and women, I say, hey, the big drivers in retaining growing skeletal muscle mass, testosterone, growth hormone, and moving heavy weight. Right? This isn't running for a marathon. It plays a big difference. Distance second, maybe creatine, essential aminos, your protein, macronutrient, distance second on a bit. So for me, I like using just a whiff of that pathway of the GLP-1, always lowest therapeutic dose with any therapy that I use.
how's their growth hormone? What does their testosterone look like? And so trying to have that to support it, that way we're not just hanging our hat on one tool or one mechanism.
Yeah. Which then, because I think that's where people say, like, it's cheating, because, okay, well, you lost all that, but then what's gonna happen if because they do say, well, if you ever come off of it, then you're gonna gain back the weight and you're gonna gain more, which would make sense, because if you've lost muscle mass now, then now you have something that was keeping your metabolism is gone.
And I guess us, dumb down way to put it, say, hey, if we go fast food or we go sit down in a restaurant, that's cheating, right? We're not harvesting our food, right? Is that cheating? I mean, really put a level playing field, much less the different chemicals. I mean, really just kind of dumb it down. Again, I look at, as an internist, I develop my list of top 5, top 10 least favorite medications. In the right clinical scenario, I'll use those. We'll talk about risk benefit, right? I don't like the acid suppressants or omeprazole, private people use them over the counter. One of my top 5 least favorite. If you got blood in your stool, you're vomiting blood, you got a gastric ulcer, you're going to use it momentarily.
And then get off of it pretty quickly as soon as you can, right? Because that's definitely
that one gets. Sometimes I get a little sarcastic.
And in our industry, that one's a big deal, because we have heard so much about how it attacks the muscle, and so again, we go back to, but you need that muscle. Why would you take something that's good? But then I do understand that in some cases, people are so heavy that they can't really move effectively enough to really get their feet up under them to get any results from their workout. So something like that in a low dose may help get enough weight off of them, so now that their body's able to actually do it without just killing their knees and back and everything else, right? So they can actually move to actually make a difference. But hopefully, I'm assuming when they come to you too, you're going to tell them, like, you need to get in the gym, you need to be lifting weights, you need to be moving your body in addition to this. You're not just going to take this drug and I know people have done it, right? Just take the drug and then still keep eating the way they were eating, and their lifestyle didn't change. So you're going to be in trouble on that road with that, I would think. So I know we've got to wrap this up, but most effective ways to lower blood pressure and cholesterol naturally, and is there a mineral or vitamin deficiency that has anything to do with that? This was the question coming in from Facebook. So most effective ways to lower blood pressure and cholesterol naturally.
Okay. The cholesterol one is, in my experience, has been a lot easier. Coming back to the medication part, say statins top 5, I'll use it in the right scenario, but there's a ton of other things that are effective in lowering it. Red yeast rice, plant sterols, high doses of omega-3 fatty acids. There's a number of things. And as much as an advocate I am for a plant-based diet, it's not black and white. Some people can really shift their diet. You see a reduction in lipids. Others, not at all, right? Then I would say, hey, if there's room for improvement, with cholesterol, unlike that A1C, it's a tried and true 3-month mark with cholesterol. If it takes some mental currency wherever you are on that food continuum, put a month into it and then repeat your cholesterol levels and see if you can use that dietary choices that therapeutic advantage with. Otherwise, there's a number of safe supplements that you can take to drive those down. Importantly, B3 plays a role in bringing down triglycerides, improving HDL levels, and one that comes in blood pressure is a little bit tougher. Right? From a functional standpoint, the formulaic standpoint, there's 1 or 2 products that are vendors that I use that tout for blood pressure. I think from a general standpoint, it's really high doses of fish oil, really high doses of magnesium, really high doses of what's our precursor, nitric oxide.
And most people are deficient in magnesium. That's one of the things that we hear all the time. So that pretty much everybody, even if you're eating right, just because we don't have it in the soil anymore, is like we used to. It's just not there. So even if you are eating right, you may be lacking in that. So that could help drive blood pressure up as well.
And of course that HPA access, right? And balancing cortisol, the sympathetic overtone was really higher, so making sure that part's down in. But that one gets a little bit more challenging. But that's always the overarching goal: is, hey, can we dial these other parts in? Vitamin, I didn't answer earlier when asking about the vitamin D. Another good general recommendation is vitamin D in an optimal range. Right? Typically, we want to see it above 30, below it, it's deficient. But I think a sweeter spot on vitamin D per lab or reference change is about 60 to 80 The reason I mentioned that, I did my residency training in Cleveland.
Okay.
Right? So my first 8 months up there, I didn't see the sun.
Right.
And I started
Great.
I started really seeing an impact on my mood, and I started reading articles on seasonal affective disorder, vitamin D.
Yeah.
Right? And some people will say, man, I notice a difference when I take that, right? It's not a panacea. I like, hey, what were again the low-hanging fruits to help improve those things.
Heard about that in Detroit as well. You know, it's,
Yeah.
it's kind of gloomy every time I would go there. Were you at Cleveland Heart Lab or
University Hospital.
Okay, yeah.
Interesting. Lots of good stuff, but so we want to have you back again because we just still have a ton of stuff that we would love to go over and pick your brain on. But he's been a wealth of information.
Oh wow!
And,
wasn't this awesome?
I want him to tell you guys a little bit about how to reach him if you want to get up with Dr. Shear, have any testing done, have him help you out with your medical needs. So how can they find you? How can they reach you?
Perfect. You can reach me and or my spouse, we can talk about that, who's in dermatology, aesthetics, at trianglefunctionalmedicine.com. You send an email to info@trianglefunctionalmedicine.com. Be happy to see you and point you in the right direction.
Okay, and we'll put all of that information in the show notes as well, so that you guys will have that, or you can just text me and we'll get that information to you as well. But thank you so much.
Absolutely. Thank you. Yeah, thank you guys for having me. Yeah, much appreciated.
Pleasure.
Appreciate it. Thank you so much.
Thank you.